So now I would like to present our first keynote speaker. His name is Dr. Eliseo Perez-Stable, and he is currently the director for the National Institutes on Minority Health and Health Disparities at the National Institutes of Health. Who has heard of the National Institutes of Health? Yes, that means you know about research and science and how important the NIH is. Good. Well, this man joined the NIMHD in 2015 and has been cultivating the Institute's position on the cutting edge of the science of minority health and health disparities. Through this effort, the Institute has produced a collection of resources that guide and facilitate the conduct of research to promote health equity. As in, this man be helping us teach everybody else about what it means to be a minority and how that affects our health, and making sure that that is something that is well known. And so we have him here with us today to speak and tell us his story. Please give him a round of applause.
All right. So good afternoon, everyone. It's really an honor to be here with you today. I wasn't involved in any of the foundings of any of these organizations, although with Elena, we did start a Latino physician organization in California that goes way back, also to the 1980s. But I'm here to talk about NIMHD and talk about NIH and science. I'm really thrilled at the promoting of science. I think that's what we do. That's our currency at NIH. And so let me jump into it. First, I want to talk a little bit about myself, just to share my path with you. I'm from Cuba originally. I came to the US as a child. I was a refugee at the time, so there were no issues there with documentation, et cetera. In fact, people used to ask me, "Do you come on a boat?" And I said, "No, I got a Pan Am flight." English is my second language. That's always my excuse when I don't remember how to say something in English. I went to Miami. I was in Miami for high school, college, and medical school. It was University of Miami in 1978. There were 14 Latinos in my class of 150. There were, I think, 8 women and maybe 4 African Americans. So I'm so delighted that times have really changed. I went to UCSF for residency, and primary care became and continues to be my clinical passion, although I stopped practicing medicine when I went to the NIH. And I really was impacted by the HIV epidemic. And as I thought about it over the last 2 years, there's so many parallels with what happened with COVID, very different in many ways, but also there's some similarities. I got into research after doing a research fellowship and was thrilled to learn about clinical epidemiology and methods and how to do measurement and be able to see flaws in clinical studies. And that led me to Latino health. I was really enamored with doing a project as a fellow on patient-clinician, patient-doctor communication. I didn't know how to do it, and I never really did, but that's what got me into this field. I joined the faculty at UCSF, and there I discovered collaborations with other scientists, primarily behavioral scientists and eventually population scientists, so epidemiologists, statisticians, and other disciplines as well. And I actually got an R01 at the ridiculously young age at that time of, was it 33? Which of course today is rare, unfortunately, given our ecosystem of research. I was into behavior change. We did a study in community on tobacco use and tobacco cessation, and just in general focused on the Latino healthcare. So that's what we call it, Latino. We call it Latino healthcare. After I became associate professor, I partnered with Eugene Washington, who is an obstetrician gynecologist, African American. Currently, I think he's like the chancellor at Duke. And we formed a center, the Medical Effectiveness Research Center, with funding from what became HRQ. And it was a partnership of disciplines, and it was the power of actually forming an alliance with the, probably, there were only a handful of minority physicians at UCSF who were faculty and researchers. And here's an African-American and Latino joining forces. And I think that sent a very powerful statement at the time, thinking back that was 30 years ago. In the late 90s, we got funding from the National Institute on Aging to do minority aging research. That grant is still going at UCSF after I left. And then really the focus on diversity in medicine and science really, as I was mentioned earlier, it's just become a central part of what I do, even if I don't have a lot of programs in that at NIMHD, and I've not done the research in that, but it's such a critical area that I always talk about it every chance I get. So why did I move to NIH? I had a pretty good in San Francisco. It certainly wasn't the weather that got me to Washington, right? So I spent 4 years on the National Institute on Aging Council. Each of the institutes at NIH have an advisory council, a scientific mostly advisory council. And there I really got to know what NIH was like. I really learned about it from the inside, because as an investigator, I never did a whole lot of like, let's go talk to people and find out, or go to meetings and network. I went when I kind of had to, and talked to program officers. Some of them were good, some of them were not. But in general, that really changed my perspective on what NIH was like. So when Dr. John Ruffin retired in March of 2014, a number of people asked me, "Oh, are you going to apply?" And I thought about it, and so I ended up applying. And I really was absolutely thrilled when Dr. Collins called me, actually just about 7 years ago. It was just in mid-March, to offer me the position. It's really about science. That's the currency. It's actually impact. It's a national stage. Everyone wants to be my best friend because we have a budget. But it also, what I say and what I do, and what the Institute does, has meaning everywhere in the research area. And I think that nothing I could have done at UCSF would have come close to that. I also have a seat at the director's table. So, and that was actually a colleague who's now retired, Bob Croyle, was at NCI. When he called me in between my first interview and my second interview. Second interview is when you're a finalist. And he said, it's not just about running an institute and thinking about science, minority health, but you're at the table with NIH leadership. And you represent an area of science that really hasn't been represented there before. And that kind of really influenced me in thinking about, boy, this could really be a good synergy. And NIH is extremely collaborative. I'll just mention this now because I'll forget. There are many research opportunities there for students. There's a program called Medical Research Scholars Program that usually we take students after the third year. I just did interviews this week for that. And it's a residential year at NIH. And it can be a terrific opportunity in the whole spectrum of science, because we now have built up a population science, minority health, disparities. There are enough investigators doing that I think that option is there. And then the focus on diversity of the biomedical workforce is really central. And of course, there are many challenges I won't bore you with. So let me start by and I hope that you can see the slides better than I can. But anyway, what are the things that science can do to reduce inequities? How can we leverage what we know and what we will learn to do this? First, I would say we need to standardize measurement of factors that affect health. And that sounds simple, but in population science, clinical science, social science, we often have people doing different ways of measuring things that are really important. That has to end. We have to use common measures and be able to then pull them to be able to facilitate discovery science with big data. And for any of you who have inkling of interest in data science, we need people in data science, and we need diverse scientists in data science. It absolutely is a growth industry, and we really have to make that happen. We also have to be an engine for promoting diversity of the scientific and clinical workforce. I don't think I have the data on the slide. So, right now, 14% of U.S. medical school graduates are from an underrepresented group. 14% of newly minted PhDs in the sciences, so social and biological sciences, are from underrepresented groups. The pipeline is not empty, and yet we are lagging way behind in our hiring and our R1 grant awards. And I think this has reached the point of crisis. The community engagement time is here. And the COVID pandemic has really brought that home. I'll show you how. And to build trust with our communities is really become a central issue. And I think NIH leadership, Dr. Collins and Dr. Tabak, both are extremely supportive of this now. And I think this is a moment to make that, to create that infrastructure. And then just in general, we need to implement what we know. We know that treating blood pressure is good. And yet it is African Americans and Latinos, except for the West, that have the lowest rates of blood pressure control in the country when you look at national data from Medicare. So NIMHD has the first 3 bullets on this slide are the populations with health disparities that were assigned to us by Congress in our legislation. So the racial and ethnic minorities, as the census defines them, so that could change if the census changes that. All poor people of any color will be included in our target populations, and underserved rural residents. That was part of the legislation. In 2016, after a process that was gradual several years before I arrived at NIH, we declared sexual and gender minorities, LGBTQ plus populations, as a population with health disparities for NIH research purposes. I think the lack of data drove that, and that's changed, and that has led to a lot of progress in that area. And so we embrace this unifying principle that all of these populations suffer from social disadvantage that in part results from discrimination or racism and being underserved in healthcare. And that's a unifying factor for all these populations. So a health outcome that is worse than any of these groups to some comparison population is what we define as a disparity. Not every difference is a disparity, and not every outcome is worse for these populations. So keep that in mind as you move forward. Bore you with the 2020 census. I'm sure many of you, hopefully all of you, filled this out. They still have the 2-part question, even though the census wanted to change it, the prior administration did not accept it. So you have this question about determining ethnicity. So you get always qualifiers of non-Hispanic this, non-Hispanic that, which you can tell I personally dislike. And they offer Mexican, Puerto Rican, and Cuban. And the other group is the second largest group, with Mexican Americans being about 60% in the US. Those are the categories, those are the names. What changed in 2020 was whites and blacks were for the first time asked to define their country of origin in an open-ended way, or list of countries. That's the first time the census has done that, and we'll see what the results are. Those haven't been released yet. And they changed the way the algorithm for defining more than one race, and so that the proportion of Americans who checked off more than one race jumped from 3% to 10%. The largest group there were Latino Hispanic populations, just to keep that in mind. And then I just reiterate that Pacific Islanders, Native Hawaiians are not Asian. There's a different race, and they always get lumped in as Asian, API or API, and that's a big mistake. That's not the topic today, but I just thought I'd throw that in there. So Latinos really are a unique population on the globe in many ways. Latin America has been an admixture laboratory for over 500 years now. The history of the 16th century in Americas is fascinating. It wasn't just Spanish conquistadores coming over. There was people from all over. Spain was sort of the crossroads from Africa and the Arab world to Europe. There were also a lot of indigenous people in the Americas, and in Latin America, they were not killed off or totally marginalized. And the mix with the forced migration of Africans and even some Asians that came is what is Latin America today. I mean, we are that mix with various proportions across the entire hemisphere. Comparable mixtures occur in South Asia, probably for over 20,000 years. South Asians actually are more, they're really closer to being white than they are to being East Asian. And the mixture is really with Africa more than with East Asia. And then also in Hawaii, interestingly, over the last 200 years, the mixture of Native Hawaiians, Pacific Islanders, whites, and East Asians there, Japanese and Filipinos primarily, has led to another mixed population. So just some data on demographics of Latino populations. These are dated from 2013, but at least as released by the CDC, the most recent. So address the myth that, all Latinos are different. How can you mix them all up? So I'll try to communicate that we can do a group. Notice, less education, dramatic differences, even among Cubans and Puerto Ricans that have more education. There's still more than twice as much less than high school than whites. And actually the cutoff might be college now, because the data on if you get a college degree, your health is much better compared to the rest of the country. And that's, I think, something to show. Limited English proficiency makes sense. Percent below the poverty level, more than double the rate. So these are data, again, to show that. There is this thing about the epidemiologic paradox that maybe by the time I die, it might be disproven, but I haven't seen that happen yet. So if you look at the social economic model, Latinos should really have bad health. Really have we right up there, right behind African Americans in terms of all the mortality and incidence and all this stuff. And yet that doesn't happen. COVID may have influenced that now some. So the outcomes are better than expected. It was Coco Marquides who first coined the term the Hispanic paradox in the 1980s, based on infant mortality in the borders. And that observation, everyone has said, oh, it's not true. It's going to go away. Oh, people acculturate, they're going to acquire American habits and all gets, the chronic disease. Yet here we are, 70% of us, Latinos, of you, were born in this country. We're born in the United States. We're not an immigrant population anymore. We have a big important component of immigrants, but we're not the dominant immigrant population. And yet the outcomes are still better. At every way you cut the pie, we do better than white Americans. That's the reality. There are always exceptions. There are selected cancers and some conditions, of course, that we do worse that are important to point out. So this issue of, is the life expectancy advantage due to immigrants? Some people are working on that, but I haven't seen a definitive study on that. I also started NIH and NIMHD that race ethnicity as a self-identified identity of social construct, and there is no argument about that at our level at NIH, and socioeconomic status are really critical in influencing health. And we should always be considering them in anything we do, both clinically in caring for patients and in research. And you'd be surprised how many clinician investigators at NIH 5 years ago had no idea about this, or they never bothered to check. Race ethnicity, yes, because that sort of became a habit 30 years ago, but not the perspective of social class. Some examples: Latinos have lower rates of lung cancer, even after you adjust for the amount of tobacco exposure. And that's been now shown in 2 very well done studies. Unexplained. No, we don't have an explanation for that yet. Most chronic diseases are more common in people who are poor. And it's not the thing, oh, they're just behave poorly. No, that's not the reason. There's a lot of structural factors that help contribute to that. And then within the diagnosis of diabetes, in the Northern California Kaiser registry, all race and ethnic minority groups in that data set of about, I think, 60,000 or so people with diabetes, minorities all had 30% less heart attacks, 30% less heart failure. These people with diabetes, same health system, similar care, yet less heart disease, but twice as much end-stage renal disease needing dialysis. So what was that about? I don't think anyone really knows. And so when scientists don't know something at all, they kind of tend to ignore it. And so I keep bringing it up until one of you smart people discover something. Mortality statistics are of course, now made worse by COVID, but you can see some of the trends here in younger, mid-age adults, 25 to 44, marked increase after 2014 for Blacks and whites, and Latinos also went up. A lot of this relates to the opioid use epidemic, which has been exacerbated by COVID, as we learned not too long ago, in terms of overdose deaths. And it was really to see how much disparities between Blacks and whites for mortality had been essentially eliminated after 65 years of age, which happens to be when you get Medicare, but that might have something to do with it. Now, the quality of life may not be the same. The Blacks get to 65 with worse function than whites do, but that's an accomplishment, I think, that we were proud of. Of course, that may also have gone out the door with COVID. I do notice Latino Hispanics are way down there, and when when you show the data for mortality differences, the Latinos in the U.S. look like Western Europe or parts of Western Europe, and we've done work with Latin America where you see the spectrum, and it's actually quite similar. If you take Puerto Rico as a separate country or the countries in Latin America, you see mortality is lower for the leading causes of death, so cancer, cardiovascular disease, and stroke. These are the data on socioeconomic status and mortality. And I don't know how many factors have this kind of relationship. So if you're under the poverty level for a family of four, roughly $25,000, you're 3 times more likely to die from anything than if your household income is $115,000. $115,000 is well off. It's twice the median income in the US, but it's not wealthy. So I think the message here is this really is important. We gotta know where people are coming from, and yet we don't measure it, not routinely, not in a standardized way. Maybe tobacco use and high levels of BMI will have similar relationships. I've done a lot of tobacco work over the years, so just show this for fun. You see the rates for Latinos combining men and women is quite low. It's at goal for the country, less than 10%. But do notice the education gradient. And this stratified perspective is really important. So it's not just about race, ethnicity. We have to look at it with social class as well. And we have to, and gender, and geography. So we have to do as much stratified analysis as possible in this way. This is another example that I like from the CDC. And this is the prevalence of obesity among youth by education level of the head of household. So notice that, and this is, I'll explain the graph. So on the left side, the high numbers are all for head of household less than high school. On the right side, head of household has a college degree. And you can see that for every race ethnicity that has been studied here, the American Indians are not included, you see a marked decrease in prevalence of youth obesity. But guess what? Black and Latino youth, both males and females, start off at much higher rates, and especially Black females get much less benefit from the educational improvement of the head of household. So this is the kind of research we need to foster more of when possible. And then here's an example where we don't do worse. We actually do better. This is suicide rates through 2015 over a 10-year period. And again, you see the combination by residential urbanization. So this is trying to compare, rural versus urban. And in general, rural dwellers, and this is 18% of America lives in rural areas, not the extreme rural, but in rural areas. They have higher rates of suicide, particularly for the American Indians, Alaska Natives, which is reflective of the reservations and areas around the reservations. And Latinos also do worse, but overall, Latinos and African Americans have lower rates of suicide, and that's not ever been fully understood or explained. The social determinants of health, again, are getting a lot of attention now at HHS and in our research. I talked about the demographics, which the individual factors, where you live, your cultural identity, et cetera. Language, of course, in our population is important, literacy and numeracy. But the structural social determinants have really the ones that are getting a lot of focus now. And often people, that's what they really mean when they say social determinants, but I think both are really important to consider. And MHT has developed a website, or we're part of a website that's the Phoenix Toolkit, where we said these measures are vetted by NIH. So we're putting them on the website, and now we're asking all of our grant applicants to say, you're going to use the measures that we've vetted. And they'll have basic things like how to ask about race, ethnicity, and income, and education, the everyday discrimination scale, and other individual measures, as well as now we're working a lot on the structural social determinants. We completed one phase. We just launched the second phase, and this requires like an expert panel of national experts that we convene. It takes about a year to do each of the phases, and so more to come on that. We also developed a research framework, the staff did, early in my time there, to really capture the complexity and the richness really of the science behind minority health disparities, the different levels of influence going from individual to societal, and all the different dimensions. You know, the biology is important, and it has been an explosion of information in the last 2 decades. We always started mostly in behavioral efforts and social cultural efforts. The physical built environment research really also started about 2 decades ago, when the information exploded about what the importance, why is the zip code more important for your life expectancy than your genetic code? And that kind of a perspective is really important to consider. This does not pretend to be causal or comprehensive, but if you ask for an arrow, it probably would go from right to left in most things. And the healthcare system is down there because, well, I'm a primary care doctor at heart, and for the 20 to 30% of adults that have chronic disease that need to see clinicians on a regular basis and depend on that, this has a huge impact on their outcomes, and we can reduce or make disparities worse in that context. So let's talk about COVID. 2 years ago, when COVID, the impact on minorities, on disparities was becoming evident, I'll never forget the time when Dr. Fauci was there on the stage at one of those daily evening conferences and talked about the disparities focused in on the African-American community. Here we are almost 2 years later. Well, we wrote a commentary in JAMA that was, I think a lot of the point are still very much true. Hopefully we're at the tail end of the worst of the pandemic, but we've said that before. So let's wait a few months. The 2 to 3 times the rate of cases, hospitalizations, and deaths. Every single time I've looked at the CDC tracker, we haven't really made that gap go away. California has data, all the states have data, and you can look at different regional data, but this is national data. Latinos, African Americans, and American Indians, Alaska Natives, 2 to 3 times the rate. There aren't too many things that we know about in health that are that different. Really just mind-boggling. And it's due to the exposure, the social risk. So when you tell someone, go isolate at home and work from home, well, no, I got to work in the restaurant. I got to go to the grocery. I work at the grocery store. I can't isolate. Isolate in your home. If you're exposed, you isolate in your home. Well, 10 people live in a 2-bedroom apartment with 1 bathroom. How can you isolate? And that's what was totally missing in the early stage. They were saying, oh, there's more diabetes, more obesity. That's why, that's severity. That's not infection. And I think this was a message that initially came through. We've made progress. I think vaccine hesitancy, I think Elena alluded to the mobilization of the professional community, the Latino professionals and the Black African-American professionals really stood up and did their part and continue to do their part. We are still lagging behind in the 3rd dose for African Americans and Latinos by significant amounts. We kind of caught up with the vaccine, the 2 shots, we're close, and then boom, the 3rd dose is essential, and we're behind again. So keep up the effort. I think all of you as students really can make a big difference because it is a trusted voice, a trusted messenger that has to deliver. This is not getting the celebrity or just having Dr. Fauci say something. It has to be all of us at a very much of a ground level. I was part of a group that looked at this analysis, excess deaths in 2020. Again, you see men more than women. Again, the rates for Latinos and Blacks and American Indians, Alaska Natives, much higher than for whites, and in this case, also Asians grouped together. And for women, the same relationships, although the absolute rates were lower. What was the NIH response? And I will say that 2020 was a scary year, an exhilarating year, and a nonstop year. And if I had never worked so hard in my life, even as a resident, working 100 hours a week back then, that was physically draining. This was just everything. So we stood up this RADx-UP initiative, the rapid acceleration of diagnostics for underserved populations. The Congress allocated a supplemental award to NIH to basically develop tests, the technology for tests. More tests were needed, and that was another institute that did that, and they did a fantastic job of it. All those rapid tests that we have now on the market are really a product of that effort. Dr. Collins said, well, what are we going to do about disparities? And after thinking about it, he told a group of us, we're going to allocate $500 million for you to think of something to do about the reducing disparities, and it has to be testing, because that's what Congress gave us the money for. It has to be testing. So we stood up these now 130 projects across the country. This is all the sites that are covered. Essentially, the whole country is being involved. We have 10 projects that are focused exclusively on American Indian, Alaska Natives. Of course, many of the projects are including Latinos. This is a snapshot. We funded a fantastic coordinating center in Duke. One of the PIs is Latino. One of the PIs is African American, and Warren Kibbe is the third PI. He's the data guy. He used to be at NIH. But you can see we've gotten over 1 million people tested and participated in different studies. So this is a massive effort. I co-chair this now with Richard Hodis, the director of National Institute on Aging. And it has been, it's a constant, we probably have at least 2 meetings a week to discuss this. Here's some sort of brief highlights of some of the early results. So lived experiences of Black and Latino people in this one study published in JAMA Open Network influenced vaccine hesitancy. The researchers and physicians need to engage in dialogue to build trust instead of marketing campaigns. When we did the Moderna trial, the clinical trial for the vaccine was going on in the summer of 2020, Francis Collins was worried that it was going to be too many whites in the study. So he convened us every Saturday morning for 12 weeks, Dr. Fauci, Dr. Jerome Adams, the Surgeon General at the time, and the Moderna leadership, and Gary Gibbons, the director of National Heart, Lung, Blood Institute, and I, and a few other people, to talk about what do you need to do. They had developed these fancy, not the Moderna people, but related group PSAs, really well done. Some of them were good, some of them are not so good, targeting the minority community. And then we kind of said, what you really need, and they were talking about, we can get Oprah, or we can get a, basketball player, or get somebody to do it. And I go, what you really need is your local doctor, your local nurse, your local leader, to talk about real things, with people. And there was I remember there was a news report at the time about an African-American physician who volunteered for one of these trials. And it was a story about her, and she showed her getting the vaccine. She's I think a family doctor. And I said, that's 10 times more powerful than getting us. I mean, it's great to have the celebrities, don't get me wrong. They can persuade people. But we have to pull out, remove this idea that that's the way you attract people. Vaccine hesitancy really can also be addressed with this open dialogue. It's really hard what we have left in this country, because it is a pandemic now of the unvaccinated, or the people who have not received the third dose. Those who are dying. The data are very clear. If you might get COVID, we probably all eventually will. But if you get your doses of vaccine, you're almost certainly unlikely to die. So I think that that's not a message that unfortunately has gotten across. The other program we launched, and this is directly a result of those Saturday morning meetings, was SEAL, the Community Engagement Alliance. And this has been transformational in many ways. It transformed the NHLBI into saying, we're going to do community engagement. And we didn't put the money from our institutes, except a few $1 million. Most of it came from the Operation Warp Speed, from the NIH, and from the department. 21 teams have been funded. There's one in Pennsylvania, New York area. I'm not sure there's one in Pennsylvania, actually. I think there is one in Philly, yes. The DC, Baltimore, Virginia area as well. California has, and so this is built on partnership. So we start with community and academics together. And we have really created a model, I think, for the NIH to follow, both for recruitment of diverse, inclusive participation in clinical studies, and it's being used for that now for COVID studies, as well as actually moving the needle on what the communities think and how to address the disparities that exist. So we have ideas that we can create something like this or do something like this for the vexing problems that we have in our communities, diabetes, extreme obesity, and other behavioral issues as well. Communication has been a strength of SEAL, and we lost that battle as scientists. We really lost that battle, and no one saw it coming. The misinformation, malicious at times, not just naivete, but malicious misinformation, it really pulled us down in what people started believing. I remember when we were at the National Cathedral in February of 2021, doing a Promote the Vaccine campaign with faith-based leaders in Washington. And Dr. Fauci was saying, well, they're saying that you put a chip in there, you can change your DNA. Where did they get that from? And lo and behold, people actually believe it. And we can't dismiss that. We can't just say, oh, no, you're not. We have to really address it. We have to listen. We have to just do sort of gradual, consistent persuasion. That's the only answer I have. Mandates are not going to work anymore. And we know that already. The Supreme Court took care of that, as well as the fact that people don't like to be told what to do. So we have to do the persuasion route, and it's going to take time and it's going to take effort, but we have to be straightforward and consistent. And not this nuance, well, there might be a small risk of this or a risk. The scientific talk doesn't cut it in delivering a public health message. We really have to be concrete and unequivocal. It's not like you're debating a topic with your fellow scientists. So let me finish or turn to an unpleasant topic, which is racism, right? This never was a polite conversation, right, at the dinner table or in a cocktail party. And in fact, many people avoided it. At MHD, we couldn't. Now, it was part of what we always were doing and talking about it. And this is data from 2015, where the Kaiser Family Foundation asked a national sample of Americans, Latinos, African Americans, and whites are the only sampling frame that they reported on. And 36% of Latinos, over a third of Latinos, said that in the past month, they were treated unfairly because of their race or ethnicity. In a variety of settings, including healthcare. Now, healthcare did a lot better, but it's a sobering fact. Now, African Americans is over 50%, whites 15%. So we have a problem. And I think 2020 is going to be significant also because of somewhat of an awakening, although there's very much a return now to trying to go back the old way on this. This didn't come across well in the transfer of systems, but we look at research as racism as a research construct. These are categories that we use. Almost all the work that you have read about or heard about is in interpersonal research, interpersonal racism. So have you perceived racism, discrimination in your life, like what I just showed you? Great measures have been developed, strong associations with a variety of outcomes, mostly behavioral and mental health, but some cardiovascular as well. And then a variety of other categories I'll skip further. Structural racism is what we're dealing with now. And this is the notion of history, culture, institutions, policies that were codified that perpetuate inequity by creating this ideology of inferiority. It really sends the message in some explicit and subtle ways, in many subtle ways, that this group is better than this group. And that's the way society sees you. And that's what we live every day. And acknowledging that that's a problem is step one, but it's not the only thing. It really has its foundations in the modern era, I would say. Of course, go back, there's slavery and there's Jim Crow and a variety of other factors. In the residential segregation as a cornerstone, this was actually developed and implemented in the 1930s under a Democratic presidency, and really began to impact the United States after World War II, when all those GIs came back. US was at the top of the world economically and militarily. And how do you build equity in this country? You buy a home. How do you buy a home? You borrow money from a bank. Well, they drew lines through neighborhoods and said, this neighborhood doesn't get loans, this neighborhood does. The neighborhoods that didn't get loans were the Black neighborhoods. And that led to the beginning of the deterioration of those communities. And Latinos followed. We were 20 years behind. They came later with this. Now it's illegal, so they say, oh, it's illegal now. It's all history, but the effects are very much being lived today. Lack of economic opportunity. The schools, the schools aren't good. I lived in San Francisco for 37 years, a wealthy city. The Hunters Point Bayview area, which were a lot of African Americans, did not have a single full-service supermarket in that whole neighborhood. A lot of liquor stores, but no single full-service supermarket. So you tell your patient, go buy some fresh fruits and vegetables and eat healthy. Where are they going to go? There were no stores that they could go to. So we're working on this. We had a workshop a few years ago. We now have a number of R01 grants that we'll be funding. They haven't been finalized yet. The NIH Common Fund has launched a process for this, and I'm part of that. That's been cleared. It's going to be transformative as we develop it. There's a lot of partners. Shannon Zenk, who's the director of the National Institute on Nursing Research, is actually very much focused on this as well. She's a population scientist. So how has racism and discrimination impacted Latinos? Some Latinos would say, well, I don't ever experience racism. And that's a lot of people say that. So we have the highest rate of uninsured in the United States. Less access means worse management of chronic conditions. That's structural racism. They say, oh, it's all those undocumented. No, it's the kind of work you do because it doesn't provide benefits. That's the main reason you see that, not because of documentation status. It is made worse by being undocumented. Immigration has been sort of this factor in mistrust to participate in research. Suddenly research, and this is a challenge for the young scientists in this room or to-be scientists, everyone says, oh, NIH, it's government, we don't trust you. But yet everyone, including often myself, will give Google and Apple and Facebook and all the information about not just who you are and what you do, but a lot of other intimate parts of one's life. And yet people have no issues with that, but they don't want to give data to a researcher who happens to be funded by the National Institutes of Health. English language proficiency continues to limit options. Accents actually limit options. So if people interview for and they have an accent, people won't say that's the reason, but they won't hire you. You're familiar with the research that's been done where you get two identical CVs. And one looks like it's more likely from an African American. The other one looks like doesn't. And the person who's not African American gets selected, even though they have identical credentials. Whether you put in a criminal, you can put criminal conviction in both, and yet the white person with a criminal conviction actually gets more likely to get an interview than the Black person without any criminal conviction. So this is very subtle, and it's throughout our society. And I'm not blaming we can't blame any individuals. This is not about anyone's fault. This is really about acknowledging something and working with it, because I do have faith in humans and that we can move forward in this. And Latin America has a ton of racism as well. It's based on indigenous background. People who are darker are always discriminated against. The non-European features. In general, people from Latin America are shorter, and that also gets discrimination. They tend to be stockier. All these things matter, and they're not pleasant to talk about, but we have to begin to approach them with this scientific perspective and equity eye. You see, I'm running a little late. Oh, not too bad. Acculturation and health outcomes. So this has been discussed since I was a fellow. There's this belief, and I'll just put it out there, that Latinos will acculturate and we'll get bad habits and get sicker and chronic stress and lose our mortality advantage. Well, I'm still waiting for that to fully happen, although some say it's coming. So be empirical, look at the data and just interpret the data. Don't just rely on the belief that that's eventually going to happen. There are indicators that do support that, particularly the health of women around substance use in maternal care, but not necessarily in all things. I think that the answer is much more complicated. It has to do with socioeconomic status and other social determinants. There's downward and upward mobility. So someone comes to this country with an 8th grade education and they have a successful business. They have an upward mobility and their health will get better. People come here with a degree and they have a downward mobility. They end up being doing manual labor or doing some other kind of lower paying job. And they may either stay the same or get their health worse. So it's not so simple. And I think that this is what scientists call, or social scientists have called, a segmented assimilation model. So it's not linear, but dynamic and can be stratified. I'll skip this over because it's too boring to talk about that work that we did. Let me get to some more practical things. So interpreters in language discordant encounters. So this is almost like a no-brainer thing, right? If you can't talk to someone in their own language, isn't that going to affect the healthcare? And collecting empirical evidence that that was the case was really important, and doing a study that would to be able to do that. So some elegant studies have been done. The first one was done at Irvine. Patients using interpreters ask less, say less, and answer less, and there's much less patient-centered care. This is with professional interpreters, and they were not necessarily chronically ill. They were tended to be younger patients. Generally, encounters take twice as long. I took care of patients who didn't speak English or Spanish. And so what do? You do half as much because you only get 20 minutes anyway, or do you get more time? Now, what system is providing more time to take care of someone who doesn't speak the language you speak? I don't think anyone has yet. They're trying to say whether you should be compensated more if you are concordant. So who translate matters. It's never good to have a child translate for an adult, never. And yet that happens every day in this country. Or have the front desk person do the translation because he or she happens to speak the language of the patients that you're taking care of. That's never a good thing. And yet it happens all the time. You need professional interpreters. Of course, a lot of physicians in practice will say, well, who's going to pay for it? We can't. It's just an unfunded mandate. But health systems really have no excuse, and they have to cover it. It's accuracy, it's quality of care. Technology has made a difference. Maybe Google Translator will be the answer as it gets getting better. And it can work for more casual kind of interactions. But you can do video conferencing in with interpreters at a remote site that works extremely well. And you can also do in the hospital the dual set telephones where you get an interpreter on the phone, the patient's on the other side, and you're talking to the patient. The first time I did that with a Russian-speaking patient, it was really quite eye-opening that you could really speak to the patient. Ultimately, clinicians' language skills need to be tested and certified and compensated. Because they will save the system money if you are not needing an interpreter. I've drilled about the diversity in science. I do want to, the last bullet here, the equal inclusion of people from all backgrounds, especially those who have been viewed differently because of his exclusionary practices. So there's this notion of diversity as, oh, we're all different. It's sort of like snowflakes, right? We're all different. It's good to have let's taste your food. Let's do culture. That's all good, but that's not what we're talking about. We're talking about addressing historical misuse of our populations. And what we can do with the legal limits is constrained, but is not zero. And I think that's an important one to say. Patient-clinician communication is important. I will tell all of you medical students and future medical students, this is the hardest thing about clinical medicine. You think biology, genetics, or no, it's communication is the hardest skill that you will learn as a clinician. You can be a doctor that never talks to people, and that's fine. But if you're going to talk to people, this is the hardest one, and it's learnable. You got to work on it. You got to keep checking yourself. It's like every other learned skill. You're not born with it. And it is directly linked to patient satisfaction. Patients are more adherent. They feel better. They have better health outcomes. Lisa Cooper did very elegant studies that showed that race concordant visits for African-American patients were longer and more patient-centered. She did this 20 years ago, and very elegant qualitative studies. The Medical Expenditure Panel Survey, funded by the Agency for Healthcare Research and Quality, African-American and Latino physicians care for more than half of the minorities in that cohort study, and 70% of limited English proficient patients, and more Medicaid and uninsured patients. And yet I told you there are 14% of med school graduates and maybe a little bit lower for practicing physicians, yet they're doing 50, 70%. And so this is an intervention that I think will decrease disparities, training more underrepresented group physicians. And yet we haven't acted on that all these years. There's a lot of buzz about precision medicine. When I got to NIH, I think that has been tempered somewhat. I would argue that one size fits all does work for many things, and so don't discard it. You got to show that the new treatments are not only, first of all, they're not always better, but they're almost always more expensive. So equivalency is not good enough. They have to really be better in order to say, okay, now we're going to go with this drug or this approach. So don't just buy the hype about precision medicine. Precision in patient-clinician interactions is really important, and we don't pay enough attention to that, as you just heard. I would note that the exception is in cancer immunotherapy. We've learned that obtaining the somatic mutations of the tumor and identifying who carries certain receptors will lead to better and safer therapeutics, and that has been one of the factors that has seen a steady decline in cancer mortality in the United States over the last decade. How do we promote health equity in healthcare to reduce disparities? So expand access is number one. We still have too many people who have no health insurance. About 18%, I think, of Latinos are uninsured in this country. We're the highest percent uninsured in the country. The ACA experiment, I think, has worked. We're beginning to generate some convincing data that to show that it almost got it took one vote, right, to keep it from getting repealed, and hopefully this administration will get back to making it stronger over the course of the next couple of years. Public health consensus, we know what to do, let's do it. And I think hypertension is one thing, but you could say diabetes, cancer screening, there's a bunch of things that we can. I think coordination of care has a huge potential to help. So using navigators, this is extension from the literature from community engaged research of peer navigators, peer counselors, putting them into this clinical system, maybe with more training, perhaps at a higher level, to deal with the patients who have severe, often psychiatric problems and are in the emergency room, 5 times a month when they don't need to be, or people who are very sick and need a lot of support to keep them at home safely. I'm a big endorser of primary care, and I really urge as many of you as possible to go into a primary care discipline. General medicine, family medicine, and general pediatrics. It's what this country needs. It's what our communities need. But we need people everywhere. So don't take that as a dogma. We really need every possible specialty. But we have an inverted pyramid in our training. So only about a third of physicians are primary care, and they really need to be the most important part of the healthcare system. The West has done a lot better job of this, maybe because they were all public medical schools. There was more of a responsibility to the population, and areas are different. Boston, for example, has a very strong primary care history and philosophy. The DC does not. To them, primary care doctors are just referral points. IT, the electronic health record has been an earthquake transformation for clinicians. It might be secondhand for you, and that's great. I'm a digital immigrant, so as I was told when we went from paper to electronic, it was painful, but it's better care. And yet, how can we leverage that to improve health health equity. I think that's an issue. And I'm hoping that CMS will create some sort of a measure of equity quality measure that systems will be held accountable, because there's nothing like money on the table to get health systems to change what they do. I think I already said all these things about community engagement, and I want to give you some time for some questions. And MHD is interested in everything. That's the problem, but it's also the beauty of what we do at our institute. Multi-level interventions. We don't have one drug or one disease, so we really need multiple ways of approaching problems. I'm very much a endorser of mechanistic research, understanding both the biological, social, behavioral pathways. So we know what levers to push. There's nothing like putting a lot of resources into an intervention that doesn't work. That's really deflating for NIH or for the scientists. Already talked about the importance of communication and structural change to really improve disparities. So don't hesitate to reach out to us. We have resources, and we're always eager to talk. Thank you very much for your attention. I may have taken too much time, Karina, but if you have, I have time to answer questions.
So there's time for like 1 or 2 questions, and then I need to make some quick announcements. Please come up to one of the microphones to ask your question.
You want to moderate? Emilio has a question. Or
how you doing, brother? My name is Greg, Dr. Taylor. I'm here from University of Southern California, recruiting some of your fabulous students. We don't have a booth, but I am the booth, okay? Question, can you speak briefly about Healthcare 4.0?
I'm sorry?
Healthcare 4.0, the advent of artificial intelligence, machine-based learning, additive manufacturing, longitudinal care, hospital at home. Can you talk briefly about that and how some of the students, you know, maybe our educational system should be preparing our students for this new wave of healthcare?
Well, I can always talk about anything almost, even if I don't know much about it, like this topic that you just asked me about. But I can comment that certainly data science, as I said earlier, is really a critical growth discipline that we need to get more skills in. And so any of you who have inclination to that, or even if you don't, learn what it can do. It's really important. Big data can answer a lot of things. We don't need to do a clinical trial for everything. And machine learning is coming now. There's been a lot written and observed about the bias that can happen with these algorithms. And some of it relates to who is writing the algorithms. And it's both a male-female bias and definitely a bias against underrepresented groups that are not at that table. And that's why we need to be at that table. NIH is making an effort to make a difference here. There's a program that was funded this past year called AIM Advantage that is funding under-resourced institutions to develop this capacity. And we are interested in doing that as well through our research centers and minority institutions, which is a network of 21 centers that we fund. Now, hospital at home is, I did hear about that at one of the conferences several years ago, about how you could do a study where you could say low-risk patients with certain conditions could be managed at home. You know, you set them up for their, you know, maybe they have a low-grade kidney infection, or maybe they have a pneumonia that you could treat at home with nurse follow-up. Maybe someone who goes with them. And you watch them, you know, closely for the initial 36 hours or so before you consent. And the outcomes are very comparable. But the key there was a triage at the beginning. And there's also discussions when I was doing clinical medicine, and of course I'm a little removed from that now, about doing ambulatory intensive care. So you have, you know, very sick patients who need more than our usual 20-minute follow-up, who need maybe a team to see them. You know, you can see people with ejection fractions of 20%, people who have inactive cancer chemotherapy. And I came at this as a generalist. It wasn't a specialist perspective here, because ultimately the continuity of care was being done by generalists. There aren't too many subspecialists that see patients long-term. particularly if they don't have their particular condition. So I don't know if that helps, but I think it's a little bit out of my area, but thank you for the question. Yes, Emilio.
Eliseo, thank you for a really special, excellent presentation. The issue of the neighborhood effect. This is something that in the panel that you put together in 2017, there was a lot of buzz about, which is in neighborhoods, you have a compounding of all the social determinants. I mean, many, and the education, the transportation, the jobs, the crime. And is that a focus for research and intervention, knowing what we do know about the neighborhood effect?
Absolutely, and it can be daunting, right, to say, well, how can we do this? There have been some work done in creating healthy communities, so transforming communities that have been unhealthy, and by inserting access to fresh foods and vegetables, addressing the issues of criminal justice that matter to people. It's not about police behavior only, which is important, but it's also about people don't like to have their windows broken or to be assaulted on the street. Addressing access to healthcare, so having a community clinic that is close by, and then creating jobs, which is probably the hardest part that people can get to. They don't have to travel for 2 hours for. Research-wise, there are a number of studies that have been done. Probably the most the reference one that I remember is the neighborhood one that moved single moms with kids out of the low-income neighborhoods to less low-income neighborhoods. Let's put it that way. They got housing vouchers, and this was a randomized study in 6 cities. You got randomized to the voucher or randomized to do what you normally do. And the outcomes after 10 years showed that the women were healthier. They had lower BMIs, lower hemoglobin A1C. They were all young women, so it wasn't someone with a diagnosis to begin with. The pre-adolescent children did much better. The adolescent boys did worse, and the girls were kind of in the middle. So taking them out of their cultural context in those formative years of adolescence actually did harm. And so we have to look at these things differently. We're going to fund some R1s on addressing structural racism and discrimination. There are a bunch of grants that went to the agency. I don't know what the other institutes are going to do. We're all waiting for a budget. So when we get the budget, we'll spend the money. And the Common Fund, which is the NIH has this thing called the Common Fund, which I think it was under Eliseo Perez-Stable that it started, where actually the NIH director gets this big pot of money to come up with ideas to do something that's transformative and across the entire agency. And for the first time they did something not basic biological, like they did the initiative to enhance scientific workforce diversity. And that's been now renewed in a different, called the first cohort. So the hiring of faculty committed to diversity over the course of about 9 years of funding. And we were approved, or a group, the concept was approved to address structural racism. And the approach, at least as initially put, and this is public information, so I'm not revealing any secrets for those of you who, is to fund communities first and then bring in the scientists. The communities would be expected to have scientists with them, so they're not applying solo. And this substantive, it's about $400 million commitment over 10 years. And the goal is to, how can we address the structural inequities that exist? So factoring in what you just described, and we'll see. It's not going to be easy, but I think that at least we're going to try by putting some substantive resources behind it. So, thank you.
Arnold Cia, Louisiana State University. A great presentation, Dr. Perez. Quick question. In your social demographic slide that you show at the beginning of your presentation, you mentioned United States, Cuba, Central America, blah, 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 but nothing about South America. Is there any reason for that?
No, of course not. If I did mention South America, it was just because, I can't say everything in 50 minutes, right? My wife is from Argentina, so there you go. And I've lived 2 years in Argentina. and travel throughout most of the continent. All of Latin America is alike, and all of Latin America is different. And you know, I would refer you. How many of you have heard of this book and then a movie called Motorcycle Diaries that was written by Ernesto Guevara, who was Argentinian, and in his there's a phrase in there about his experience when he was in Bolivia and how different he felt. He's going on some sort of public transportation up some mountain, and how he was a white Argentinian Latino. And he was there in Bolivia where the culture is 95% indigenous, and he was probably, had no money. So I'm sure he wasn't riding him in a first-class bus. So I do think that that's one of the beauties of our population. It's not, it's challenging, and each country is different. I went to Lima. Lima is a beautiful city. Was the capital of the empire. And in the cathedral, Pizarro is buried there, actually. And we went, and they said, "Oh, you speak Spanish, so you can just, they assigned this 12-year-old or 15-year-old kid to give us the tour." And he showed us the paintings. And at one moment I realized he was saying, "Los indios, esos indios, como esos indios." And he was Indian. He was indigenous. And yet he had no identity with the paintings on the wall. A couple of days later, we were in Cusco, and there was this monument when you first get to Cusco in the open plaza. It says, "To the 500 years of struggle." Same country, same people, and yet it's a very different mentality in the orientation to this. So, no, South America is an incredible place. So, no, just an oversight. Thank you. I'm done, right? Yes. Thank you very much.